John Hirdes, thank you so much for joining us from Ontario. I think you're in Toronto in Canada, and giving some time to us in Australia to learn about something about interRAI.
It's wonderful to have the opportunity for a chat.
So I understand, of course, and many others would know, that you were recently appointed as the president of interRAI. And I think that all of us see that as a great honour. But what are your thoughts about taking up that role?
Well, it is a great honor. Brent Fries left very large shoes to fill. He was an impressive leader, a founder of interRAI, and it's a daunting challenge to sort of look forward to match his contribution to the organization. But I see it as a great opportunity. And like you said, it's a wonderful opportunity and honor to have a chance to work with so many gifted researchers and clinicians from around the world to really try to make a difference in the quality of the lives and quality of care of vulnerable people of all ages around the world.
So I do know you've been involved in interRAI almost from the beginning, but not quite. But what brought you to the interRAI community?
Well, I guess you could say I was a bit of a rival to interRAI when I started, because I'd been doing about 5 years of research myself, creating what we'll call the Hirdes assessment system. I designed an assessment methodology for use in complex continuing care hospitals in Ontario, sort of a post-acute care facility. And I was in a position to encourage the government to mandate my assessment system as the provincial standard. But just as we were beginning to make that decision, a paper was published that talked about this new methodology created by a group of researchers in the United States called the MDS. And when I took a look at this competitor, I realized they'd actually done a good job. It was a very good system, very comparable to mine, had some strengths that mine didn't have. And as I looked into it a bit more, I learned that there are already 5 or 6 countries collaborating with these folks, and that they had started a substantial international program of research. They had large-scale implementation in one country. Other countries were beginning to look at it. And I thought to myself, well, if this competing instrument is as good as what I've got, what would it take for me to catch up? And I realized it would take a very long time. And I realized the better opportunity would be for me to join forces and collaborate with folks in these different countries. So by the time I got involved in interRAI, there were about 30 researchers from about 10 countries involved at the time I joined. Now we have over 150 researchers and clinicians and policy experts that we're collaborating with in over 60 countries. So it's been a remarkable journey, and it's clear that I made the right interest to join forces with this impressive group.
Yes, and I think many of us in interRAI are very glad you made that decision. So where do you see interRAI going in the next 5 to 10 years? And how might that look different from perhaps the last 20 or 30 years of development?
Well, there's so many new opportunities emerging for interRAI. So certainly greater global uptake of interRAI systems is really possible. We now have several countries with large-scale implementations that are already well established. So New Zealand, Canada, United States, Belgium, Finland, Switzerland, Hong Kong are some jurisdictions in the world with large-scale implementations. And so scaling up the cross-national collaborative and comparative work that we've done is one opportunity. I think also expanding the sectors that we're involved in. So I was heavily involved in work around the mental health instruments. There are new children's instruments. There's the acute care instrument. And so having a bigger picture of the person's longitudinal trajectory of health service utilization is an opportunity. I'm very excited to be collaborating with researchers and clinicians in low and middle income nations with some of our new self-report methodologies to reach very large underserved populations in those settings. But I think one of the real opportunities that's emerging as well is to think about how we use new computing technology, particular artificial intelligence technologies, to enhance further the use of these high quality data that we gather as part of the interRAI assessment process.
Yes, I'm well aware that you in particular, but many of our interRAI colleagues are working in Africa and South America, areas that have really been underserved, I suppose, over the last 20 or 30 years.
Yeah, there's many things to learn from this work in countries with fewer resources than Australia or Canada. But one of the surprising things is those lessons are also applicable to our own countries that are relatively more well off. So the challenges, for example, in Africa or in South America or in India are large populations in need, limited health human resources, and limited time to catch up with the population changes that are happening. So Africa is now the fastest aging continent in the world, but they have many fewer health human resources than we do in Australia or Canada. If we think about training for African clinicians, there's very little training in geriatric medicine, little training in mental health, for example. And so if there was a dramatic increase in health human resources in those countries, the chances that those new resources would be allocated to dealing with aging may be fairly limited when they have many other pressing concerns. So we've looked at what are less expensive and easier to scale up methodologies to serve a large, lighter care population, say in primary care. That's where the interRAI checkup system for geriatric assessment and the interRAI self-reported assessment for mental health services has come in to provide a very valuable opportunity, because people can complete these assessments on their own, or a lay health visitor can assist with an interview, and it yields high quality clinical data that is interoperable with the clinician rated assessments that we do in interRAI in the better resourced settings. So it gives you the opportunity to reach large populations where regulated health professionals are not available. It articulates with the clinician-led assessment, so you can triage the most complex cases to those folks with higher needs, and you can use it in sparse or remote environments. So in Canada, like Australia, we have a high concentration of folks in a few urbanized areas. Then we have large land masses where there's very few people that are hard to reach. So we have parts of Canada where the supply of nurses and physicians is as low as it is in some of these lower and middle income nations. So what we've learned from these under-resourced jurisdictions is equally applicable in parts of Canada.
Yeah, that's very exciting to watch and hear about that work. Many countries like to build their own systems, and interRAI, as I understand it, tries to use standardized approaches everywhere with little variation. How do you see tackling that kind of balancing issue when you talk to governments or large organizations that want to have their own adaptations?
Well, my PhD supervisor had a favorite joke that he loved to tell. He was a statistician, and his joke was, somebody asked my wife, "How do you like your husband?" And her answer was, "Compared with what?" And the challenge is, if you don't have comparable data, you can't compare yourself with anything. And so if you design your own systems, you grow your own methodology, you can look in the mirror to see yourself with your data, but you can't really know how comparable or different you are from other jurisdictions. So if you want to take the opportunity to learn from other countries what worked and what didn't work, you need to have standardized comparable data to make that comparison fair and accurate.
One of the key messages we talk about, it's become popularized in Australia, is the idea of collect once, use many times. How close do you think interRAI is to achieving that in practice?
Actually, very close, and there's lots of demonstrated examples of where that happens. And so when I talk about interRAI systems in a Canadian or international context, I talk about applications from the bedside up to the minister's office. So at the bedside, you can use interRAI assessments for assessing the person's strengths, preferences, and needs. You can use it to develop a collaborative care plan with them through a shared decision-making process. You can repeat the assessment to track outcomes over time to see if they're getting better. And so there's lots of person-level clinical applications. There are some local health system management applications, so you can use this to inform eligibility criteria that are more policy-driven, value-based frameworks, but you can operationalize a value system using those data. You can use it for disaster management to understand where populations at risk during disasters are, and to do all stages of disaster planning and response using those data. You can use it for funding methodologies to inform funding decisions based on resource intensity. You can also use it to evaluate the quality of care by aggregating the outcome data, risk adjusting it, and having outcome-based quality indicators. And lastly, at the policy level, you can use it to do population level need analysis.
So in Australia, there's a perceived considerable amount of burden in reporting just the quality indicator data to government. And yet interRAI systems seem to be considerably larger in terms of the amount of data elements in the systems. How do you reconcile using a larger system like interRAI and minimizing the reporting burden that might be associated with it? What's the experience in other countries around the burden problem?
Well, the starting point is the complexity of the person receiving services. So if you think about older persons, persons with disabilities, persons with mental health needs, people who are dying, their care needs are complicated. And so in order to provide appropriate care, you have to do a comprehensive assessment.
Yeah.
So if you have to do a comprehensive assessment, you have to gather data for clinical purposes. The key is to make the interRAI assessment that clinical comprehensive assessment, because if you have to do that anyway, you will complete an assessment that is as good as any other clinical assessment that's out there, and you can use the same data for all these other applications at the same time. So there's no increased burden if you accept the interRAI assessment as the basic clinical tool.
So you're really just echoing the collect once, use many times idea.
Right. The key thing is it's collect once for clinical reasons and then use many times for other reasons.
Right. So I'm well aware that interRAI data has been used for all sorts of reasons to influence and improve outcomes for older people. Would you like to give us one or two examples that come to mind?
Yeah, so at the population level, probably the two most interesting changes in Canada have been around physical restraint use and use of antipsychotic medications. So when I did my first study with that Hirdes assessment system and the interRAI assessment in the early 1990s of these complex continuum care hospitals, I found that the rate of physical restraint use in the early 1990s was 45% of patients being restrained. And everybody accepted that as, well, that's what the rate is. When we got interRAI data from other countries, we realized that other countries had a much lower rate of restraint use. We used that to drive a policy conversation and to drive a quality improvement initiative in the country. So now the national rate is below 5%, and it's only at the 5% level in some cases because of recent provinces moving to adopt the system and realizing that they still had a high rate of restraint, even though they thought they'd made those changes. So it was a dramatic change in that particularly problematic practice pattern. The second more contemporary example was around antipsychotic use, where we have antipsychotics that were being used potentially inappropriately at a rate of around 35% in the 2014 range. There were some inquiries about whether this is the right rate, and again, when we did some cross-national comparisons, we found our rate was high. In about a 6-year period, we dropped that rate down to almost 20%. So about a third relative reduction in the rate of antipsychotic use. Unfortunately, COVID hit, and it took the initiative or took the wind out of the sails for this initiative to some extent. So our rate has crept up again to around 23, 24%. We've been working with the Choosing Wisely Canada Consortium and the Canadian Drug Agency to set new national targets. So we've now set a target for 15% as a national average, where we're encouraging all homes in the country to reduce their relative rate of use by 15% each year to get to that national target. We think we can do it, and having data in hand gives us an evidence frame to use to guide our interventions and evaluate our outcomes.
Good. I'd like to ask you some questions about technology, in particular about artificial intelligence.
Right.
So, it's all around us, discussions about
Right.
artificial intelligence and using it for predictive analytics and similar things. How do you see interRAI interfacing with that new set of capabilities? Can you tell us something about that?
Well, I see three main types of artificial intelligence to think about. So there's predictive analytics, there's generative artificial intelligence, and then there's agentic artificial intelligence. In terms of predictive analytics, I would argue that interRAI has been doing machine learning and advanced predictive analytics for 30 years. If you go back to the original work done by our founding president, Brian Fries, you'll see he pioneered the use of decision trees and computer-assisted regression trees for predicting resource use in nursing home settings. In the 2000s, we started to do more work with more advanced machine learning techniques, and now we have many researchers within the interRAI network using advanced methodologies like random forest analysis, k-nearest neighbor, all those newer machine learning technologies combined with advanced statistical techniques using more conventional methodologies. So we've done that for a long time, and we will continue to do that. Around the generative AI, I think there are some opportunities. So with generative AI, you're taking information and you're creating something new. So a text-based summary, a drawing, computer code, a video, all kinds of things can be generated from new content. Where I see opportunity with that is around better patient engagement, where we can take interRAI information and summarize it in a way that's more accessible to persons and their support networks. We can provide technologies that can make it easier for people to interpret and think about what the interRAI results are, or to get more information if they want to know a little bit more about, well, what can I do if I've had a number of falls recently? The agentic AI is sort of an interesting challenge. So with AI agents, they are sort of autonomous programs that will do things for you without you necessarily asking for it. And so there's some challenges with that technology. We have to be careful about having the right guardrails in place for that. But I certainly would see AI agents as being helpful to streamline some aspects of the assessment process. So right now, in the interRAI assessment, we capture information about the person's diagnosis, for example. And so we would look at the chart, we would look at medical records, hospital records, we would look for a variety of sources for that. We could potentially use AI agents to do some of that extraction for you to give the assessor more time to have a person-centered conversation with the individual. So within interRAI, we're spending a lot of time thinking about different ways to use different types of AIs in a way that protects the well-being and enhances the health of the individual and can reduce some of the burdens in the health system. I also see tremendous opportunity for more use of the complex data that we have available to us. So an interRAI assessment is quite a robust collection of information. If we look at the interRAI long-term care facility instrument, we're looking at indicators of frailty, indicators of the person's mental health, indicators of the person's functioning and cognition, medical indicators like pain or events like falls, and we're looking at medications and their diagnoses and their support systems, an awful lot of information. You and I can take a look at anybody's assessment and we can pick certain things out. We can notice, well, this person's had a fall and the person's on a certain medication and they're showing signs of dizziness. Maybe those three things are interconnected. But with new AI technologies on both the predictive analytic and generative AI side of things, it may be able to provide a more sophisticated insight into those complex information than us mere mortals can, where we look at maybe 3 or 4 variables at a time. It may look at a longitudinal record with hundreds of variables at a time to give us new insights.
Yep, very exciting. So turning to Australia in particular, I think many of us think that we're at a fairly important point in time following quite a lot of aged care reforms where there are problems with data and assessment systems. And so interRAI is potentially under consideration. What would you say to policymakers here about the value of interRAI for the Australian context?
The huge opportunity is first of all, you've got a rigorously developed system that with known reliability and validity. All the good science is there to ensure that these are good quality products. They create an integrated health information system. So those are all sort of valuable on their own. But the opportunity to be part of a global community, to collaborate with other countries and learn from other countries, and also give your insights to other countries is where I find the great excitement lies. Canada would not have understood that it had a problem with restraint use had we not had data from 5 other inter countries. So that comparative opportunity is important. There's also an opportunity to combine forces. The challenges associated with AI are non-trivial in terms of the science that has to go behind it. So we could each sit in our own countries and do our own thing, but if we can join forces to work together, the rate of innovation can accelerate. Also, there's opportunities to learn from other countries of what worked and didn't work with implementation as well. So being an island unto yourself may be nice, but it slows innovation, and it may risk opportunity of missing chances to do things that others have learned from.
What are some of the challenges of introducing a large-scale interRAI implementation? To many, it seems extremely challenging to have that level of change, but what are the things that one needs to think about when contemplating a national large-scale implementation?
Well, you have to have good software solutions. So the acceptance and experience with the interRAI assessment does depend on the user interface of the software, its ease of use, its functionality overall. So good software is a requirement. I would argue that's a requirement for any medical record technology. There has to be an effective change management strategy. This is a big change, and you need to have a strategy to bring along everybody in the country. So there'll be the champions who are excited to lead change. Maybe a third of the population are the champions. Maybe a third of the population are people who will do what they're told and will just go along with whatever the champions say. And then there's going to be the third that are going to be more resistive to change. You have to bring them all along, and you have to get buy-in from all of those audiences. It's also critical to have a feedback mechanism. So one of the near points of failure that we had in the late 1990s with the interRAI system is when data were coming in to our national reporting system, but no quality information, no other information was being reported back. And setting up a collaborative mechanism to report back on interRAI assessments at the population level and to generate quality applications really saved the day for us in terms of the acceptance of the implementation. And then you have to have an educational ecosystem put in place. So we have a special issue of Healthcare Management Forum that interRAI published this year. In there, I collaborated with others on a paper about educational strategies. You need a multi-dimensional approach to education. So certainly there's person-level education on how to do an assessment, how to interpret it, but there's cultural changes that have to happen. You want to have conferences. You want to build it into job performance methodologies. You certainly need to emphasize clinical applications. So a robust educational strategy is really important as well. And you need folks to be champions, to be opinion leaders, to help those who are struggling to learn on how to adapt the system, to be a resource to them.
So you and I both know that there's a strong presence of interRAI in both Canada and New Zealand. And I think you and I would say our healthcare systems and our policy and relevant related philosophies are very similar in terms of offering the public good aged care and other health services. How do you see Australia potentially working with Canadian and New Zealand policymakers, interRAI fellows and researchers? Is there something there that we can take advantage of in Australia, do you think?
Yeah, there's tremendous opportunity because of the similarities between our countries. So we're countries with similar types of health systems, similar age structures, similar value systems, similar public policy priorities. We have, similar geographic distribution in Australia and Canada, a little bit less so in New Zealand. But even in New Zealand, there are notable differences between population centers. All three countries also have a large indigenous population with unique needs and considerations. So I think our three countries are well situated to collaborate and learn from each other and share ideas and gain insights on how we can tackle some of these common problems. And then there's other countries that, for example, our European colleagues in Finland and Belgium and Switzerland that we can also learn from. Ireland would be another country with large-scale implementations of interRAI systems happening. And there's tremendous value in both the comparability of data and facing similar public health concerns and having some differences between us, because maybe we can learn from some of these natural policy experiments. Oh, if I do it this way, maybe I can have a different outcome. Or if I have a similar population, but there's different outcomes, what can I learn from what's done in those countries to understand what I might change in my own country?
Yeah, thanks. Clinicians often have their pet systems, tool sets. You were one of them once, by the sound of it.
Yeah.
And very reluctant to let go of things that they've either developed themselves or they've used for many years. And when interRAI is presented to them, there's a sort of natural resistance to change. How do you see interRAI or policymakers dealing with that skepticism that comes with the offer of an interRAI solution?
Well, there is the challenge of, I've always done it this way. Why do you want me to change now? Everybody's busy. We got a lot of demands on our time, and to have to learn something new is a challenge. And so you do have to make the compelling case for people to put out the effort to go through this change. So it is part of this educational strategy that one has to have to say, well, if you do this, here's what you get out of it. Some of the translation is relatively straightforward to do, to explain to somebody how the cognitive performance scale compares to the mini mental state or the MoCA assessment, or how interRAI's ADL measures compare with the FIM ADL measures. Isn't that complicated. And once people sort of understand what the metric is, then they can make that change. But it does take some effort. I think if we sort of focus on different populations of clinicians, we may have a different strategy. So introducing interRAI early into the education system for clinicians is an easy path to go. So if a clinician is learning how to do a geriatric assessment for the first time, get them to use the interRAI assessment. If you're talking to a more established clinician, then you have to work with them to help them to interpret some of the scales on domains they're familiar with, but also show them some of the new applications that they may not have thought of that may be helpful to them.
So you mentioned training a little earlier, but describe what a good training infrastructure and process might look like if we were to adopt interRAI in Australia. How would you imagine it should be instituted here?
Yeah, so I've been involved in training around e-learning technologies. I've also led lots of webinars nationally, and I've hosted national and international conferences. All of those are part of what I would describe as this educational ecosystem. So there's a few things that one needs to think about. So there's technical aspects to the training that have to happen. How do you measure an ADL? Do you consider the best performance, the worst performance, the average performance? Do you look at the number of episodes of performance of a given ADL? Those technical definitional things that are in the interRAI manual, people need to learn that. They need to learn about observational timeframes, inclusion and exclusion criteria. So that's all the stuff about learning how to do the assessment and complete the assessment instrument correctly. There's a problem-solving dimension to it where you have to sort of think about, well, how do I deal with ambiguities in things? So if I have competing information, if I see one thing when I look at the person, the family member tells me a different thing, and I see a third different thing on the chart, how do I reconcile that different information to make my judgment about what's the most correct answer? Or if there are complicated cases that feel like they fall between categories, who can I call on as a peer to think through the process? So there's a peer mentorship, there's a reflective practice dimension to it that you want to think about as well. There's a dispositional dimension to it of, dealing with the motivation of why I want to do this. And so you need to think about what messages do I send to learners about why they should care about doing this and why this matters to them. And the common thread with that typically is quality. Government officials want to improve the quality of care. Family members want their care to be good. Patients want their care to be good. Clinicians are clinicians because they want good outcomes. And so when you bring the education back to here's an opportunity to make a difference on the quality of care and the quality of life at the individual level, at the population level, that's a really important motivational factor that helps people do the slog to get through the technical bits that are not as fun to learn about sometimes.
So interRAI, as I understand it, has a very strong research foundation. Many of the fellows are active researchers. What do you see in the interRAI community as some of the more important emerging areas of research? What excites you in particular?
I've always been excited by the opportunity to study rare populations, populations that we have very little information about. So when I got a grant about 10 years ago to look at 11 different neurological conditions, I was excited to see that for most of these conditions, we had more data in the interRAI data holdings in Canada than leading publications in the field of multiple sclerosis or ALS or spinal cord injury or dementia, for that matter. So when you have large population data, you can understand rare and interesting groups with complex needs. You also have representativeness. So, I was trained originally as a survey researcher and got less enamored with survey research because response rates plummeted in the 1980s and early 1990s. When interRAI systems are implemented on scale, you don't have a problem with response rate because everybody's there. And so you have population level data to work with. And so representativeness is a key opportunity. Then the longitudinal nature of interRAI data is really remarkable as well, because you can follow people over time. If you have multiple instruments implemented, you can follow people across different care settings. So I can look to see how would a home care assessment, for example, predict a delayed discharge for somebody going to hospital. We could do that with the interRAI data that we have. And then one of the other new areas that becomes very exciting is record linkage, where you can connect interRAI data with medication data, for example, or laboratory data, but also new technologies like sensor technology, genetic information, geospatial information. Because you have a common core set of data on the functional and clinical dimensions of the person, you can link that to new sources of information, and you can use predictive analytics from AI to make sense of those very complex new data sets.
interRAI, folks listening to this podcast may not be aware that interRAI makes every effort to secure data from governments and other organisations as part of its improvement effort. Would you like to tell us something about that and some of the opportunities that represents to interRAI, and maybe you want to mention some of the challenges or the resistance one experiences in securing data?
Yeah, so we have a long history of working with governments and healthcare stakeholders to set up the use of our system. So we license the use of our intellectual properties to governments and healthcare organizations. In exchange, one of the main things that we receive is de-identified copies of data subject to the country's privacy laws. So we follow the nation's privacy laws, but we receive data back for research use. It's not for commercial use. We don't transmit the data to a third party, but it provides opportunity to do research. So in Canada, we've had interRAI systems in place going back to 1996. We have over 25 million different interRAI assessments that have been completed on over 6 million unique Canadians in a population of 40 million people. All those data are available to interRAI researchers and collaborators. We use the data for training new researchers and clinicians, and we've been able to gain tremendous insights into the health of Canadians and the functioning of the healthcare system with that. It also has given us an opportunity to really partner with health system stakeholders at different levels of the healthcare system. So one of our primary partners is the Canadian Institute for Health Information, who are an organization in some ways comparable to the Australian Institute for Health and Welfare. They collaborate with each other extensively. I meet at least on a weekly basis with colleagues from CIHI, and I've been doing so for decades, to talk about the implementation of interRAI systems on a national basis, to problem solve on challenges that we face at different times with the implementation, and to think about ways to use the data to inform policy decisions at all levels of government. I have similar kinds of collaborative relationships with healthcare organizations. I sit on a board of directors for a provincial home care organization and help them to think about how their interRAI data can inform some of their discussions. So it really creates an opportunity for researchers and healthcare decision makers to enter into a meaningful dialogue informed by data that can be used to create evidence to address the key questions of the day.
Turning back to yourself, and particularly about your role as president, what are your hopes for interRAI and how might you influence them over the next few years?
Well, I am very excited about some of the new generation of researchers that are coming into interRAI. There were many of us that early on in our careers made profound contributions to get interRAI off the ground and get us started in terms of multinational collaborative research. But I'm very excited to work with new PhD students, master students, postdoctoral fellows, medical trainees, and other highly qualified personnel to train the next generation and mentor the next generation of leaders in interRAI. There's such opportunity to continue to grow and have a positive impact on many of the world's problems. I'm very driven by the issue of the health of vulnerable persons in low and middle income nations. That for me is a very high priority in my role as president, to expand our effectiveness in those countries as well. And I'm also excited about some of the longitudinal opportunities within interRAI. And so with our home care instrument, we see lots of younger people with disabilities. With our mental health instruments, we see young adults in the early stages of mental health needs. I can imagine some of my current PhD students that are now in their late 20s, when they're in a similar age that you and I are, Len, looking at 40 years of data and understanding from a life course perspective what has happened to some of these individuals if they have comparable data over time. And so the scientific possibilities there are tremendous. And of course, we have a new family of child and youth instruments looking at medically complex children as well as children with mental health needs and developmental disabilities. Those children will probably have a fairly long life history of health service needs, that the future generations of interRAI leaders will have tremendous opportunities to provide meaningful insights about the human life course that we just haven't had the time to do yet in our brief careers that you and I have had.
Sounds fantastic. So interRAI is a fellowship of around 150 people from about 50 or so countries. So it's a kind of limited community in a way. How might others intersect with the interRAI community beyond fellowship? But maybe you could talk about how it works in Canada, because I think you have a pretty mature relationship with quite a large community of interest. Tell us about that, perhaps.
Sure. There's different kinds of engagement for Canadian researchers and highly qualified trainees. So many graduate students will do a master's or PhD thesis with interRAI data and may go on to get jobs with CIHI or ministries of health or healthcare organizations where they've learned to work with interRAI data as a way to look at evidence-informed decision making. When it comes to PhD level researchers or MDs, people doing more advanced research, interRAI fellows in Canada tend to be the people who want to take a leadership in terms of implementation or use of specific instruments, and who want to work internationally. So we have over 40 interRAI fellows in Canada. All of them are engaged in cross-national collaborative research in one or more of the interRAI networks. There are other researchers who are very enthusiastic about interRAI related research, but are quite happy to work in their own province or territory and don't really want to get involved in international stuff, but are very compelled to do evaluation research or more locally focused research. They are active collaborators with us in the interRAI Canada network. And there are many folks who have done that for 10 or 20 years, going back to the earliest stages of interRAI work. And then there are some researchers that are experts in a specific substantive area that will do other research for 90% of their lives, but every once in a while will collaborate with an interRAI researcher on a topic that they're interested in, because the interRAI data provide them much more robust data that they can get from a primary data collection. So there's lots of different models of how a researcher can be involved, from a fairly light touch on a limited basis to being fully engaged in cross-national collaborative research.
Can you tell us how you work with policymakers in Canada? How does that interaction work?
I would say the most important thing is listening, because by listening to policymakers, you get an opportunity to understand what's on their mind. What are the challenges of the day that they're facing, whether it's a new kind of health concern, an underserved population, a health human resource issue, a scarcity of resources and equitable decision making, or a quality issue. So I spend a good deal of time interacting with clinicians to hear what they have to say, right? Clinicians and policymakers to hear what they have to say are the challenges that they face. And then I think about, well, how can I provide helpful information from the data that we have? And what other research would need to be done to enhance that information to answer the questions that they've got. So I'm very focused on a multi-directional collaborative approach, where we find out what are the pressing questions of the day. We talk about the evidence that we have, and we work together to think about the analysis and the interpretation of results, and to formulate additional questions that may be helpful for that. And so it's not a publish the paper and hope somebody reads the methodology. That does not work. You have to be at the front lines talking to different kinds of stakeholders as part of a collaborative community of practice.
Sounds like good advice. So finally, as I said earlier, we have an opportunity in Australia to consider implementation of interRAI or similar systems. What would be your last words to our communities of interest here about the value of joining the interRAI community?
Well, I think you would find there's a global community of partners who would be very excited to collaborate with Australians at all levels. I know in my country, we've often, regarded Australia as an innovative country, a society that is like-minded in many ways, and has done outstanding work in the areas of research that they've engaged. And the opportunity for us to partner with Australians is tremendously exciting. And I hope that Australians will see a similar kind of opportunity for them to be part of a global community of people that are really committed to using high quality science to make a difference in the lives of the most vulnerable people in our societies.
Well, John Hirdes, thank you so much for talking to me. I'm sure our audiences will be really interested to hear what you've had to say, and hopefully we can talk again sometime in the very near future. So thanks, John.
Thank you for the opportunity. I've really enjoyed the conversation.
For those of you listening to this conversation who may have further interests in interRAI systems, please visit our website, interRAI-au.org.